We looked at all the parameters of diagnosis in our submodule 1, and now in submodule 2 we're going to pretty much get all the data you learn as an example of a bite of a jet, and we're going now to build a diagnostic image of the patient you will be examining for orthodontic treatment. So the course outline for this submodule 2 right here is actually to validate the diagnosis process in orthodontics. We're going to discuss the different modalities required to obtain an adequate diagnosis, how you're going to get there, how you are going to be systematic in your approach. We are going to create from the diagnosis a problem list that will allow you to better understand and build a treatment objective and a treatment plan. So the last step is the treatment plan. That is actually the result of all the steps you will have taken to get your diagnostic principles as accurate as possible. The objective of the lecture is to review the fundamental principles of diagnosis. They don't change. Every single case has to be done the same. You are going also to prepare a proper orthodontic record. In the on-site module, we will emphasize this part of the course in a more interactive way. Today is more the basics of treatment and the record system that we will be exploring and exposing and why we do it. We will also discuss the sound diagnostic principles. It's important to understand that diagnosis in orthodontics, like in every medical profession or field, I should say, is a very important aspect of what we do. And if you just jump immediately to treatment, many times your treatments will not be as successful as you would like. So we have the diagnosis, and then from the diagnosis we are going to get, how was I calling, the problem list, which is right here. You can also call this treatment objectives, which means is what do you want to do, in which order, and which it doesn't actually. This is not mechanotherapy. This is just what I want to do. An example, you may want to say, okay, there is a patient with a class 1 malocclusion. Do I want to correct it or not? So in the treatment objectives would be correct malocclusion from class 2 to class 1. That's an objective. It does not yet explain or explore the different appliances you will be using and in which order or timing. So first, we're going to review the fundamental principles. The first thing we want to do for all your patients is basically, and very importantly, to screen all your patients. This is something that you are going to learn to do any age. Any patient that comes to your office should be screened for malocclusion, be it a child or an adult. Then it's an evaluation. I call this an evaluation. It's a fairly fast way of looking at a malocclusion. You're going to observe the malocclusion. You'll decide, well, maybe I just want to reevaluate it. Patient is young and there is no point in treating right now. Or I want to intervene. How do I do that? Well, again, we're going then to switch to the full diagnostic principle. But the screening is just there to give you an idea. What type of treatment would be the best for the patient? And, well, the case is interesting, but it's too severe. And I would rather not treat this case because looking at the clues I'm getting from the malocclusion, the best way for this patient to be treated is by a certified orthodontist. The principles you're going to see are a little bit different from textbooks you may have read. So if you look at this slide, we have been trained as orthodontists to look at thanks to Dr. Engel definitions, the first thing we look at is the relationship of the molars. Everybody looks at this. It's an accepted norm. This was exactly described and very well by Dr. Engel in 1920, in the 20s I should say, where he looked at molar position and deducted that with a molar position you could pretty much decide if the malocclusion needed to be treated or not, and all malocclusion had to be treated to a class 1 occlusion. That was a very interesting statement, but it was a bit incomplete. Didn't take any three-dimensional aspect of the malocclusion, all the facial appearance of patients in consideration. So then we got in the middle here, actually we should add something, which is an important concept, is given by this picture. Is in the 1950s, Dr. Steiner introduced the systematic cephalometric analysis, and from then every orthodontic case nowadays is pretty much analyzed through a ceph analysis for the anterior-posterior relationship. You can use Steiner, there are Downs, McNamara. The type of analysis is of no great importance. We happen with Dr. K to use the Rosdowski analysis, which we'll explain, and I will also from your previous studies in sub-module 1, you notice that we also have the McGill analysis, which is actually a mix of Steiner, Downs, some widths, and it gives us a fair idea of the type of occlusion you will be looking at in a AP and vertical dimension. And then in the 1970s and 80s, Dr. Profit was a very well-known orthodontist, as you know. I'm sure you've read. Dr. Ackerman is actually an associate of Dr. Profit in North Carolina. They decided to say, okay, the malocclusions here from Engel define class 1, cephalometrics, define the AP and the vertical. But at one point there is also other things like transverse, monocrowding, overbite, overjet. So in the very landmark article which we are going to reference you to, these two orthodontists describe a whole lot more diagnostic data that you have to look into getting a proper diagnosis. So we went from Engel to cephalometrics, and then we're going this way, right? But what you have to remember is the main thing is that what the patient sees is actually his or her face. They don't have much interest in cephalometrics. They don't have much interest in molar occlusion. So what you need to do nowadays, what we treat in North America and Europe most probably, is we're looking now at an outside-in approach, which we're going to pretty much spend the whole lecture on today. It doesn't invalidate the class 1 or the cephalometrics. It's a little bit of a different way to look at patients from the soft tissue envelope. So nowadays what we're going to see today is how to do this, which is now a patient-centered and not a doctor-centered concept.